Good morning, everyone. Welcome to the latest episode of PYA's Healthcare Regulatory Roundup webinar series. Today's topic is 340B Update, where we are and where we're headed. PYA is happy to present today's webinar on this important topic. You may submit questions during the webinar by typing a message into the questions pane of the control panel. Also, immediately following the end of the webinar, you'll be asked to complete a short survey and submit any additional questions. We'll respond to questions posed after the webinar via email. We've posted in the handouts pane of the control panel a PDF copy of the slides for your reference. Also, you'll receive an email later today with a copy of the slides and a recording of the webinar. With that, I would like to introduce our presenter, Sarah Bowman.
Good afternoon, and thanks for joining today's Healthcare Regulatory Roundup. Today we'll be discussing 340B. My name is Sarah Bowman, and I'm excited to be with you today discussing this important topic on how providers such as yourselves can maintain a compliant environment and stay informed about the latest challenges and updates that are happening in this space. Today's presentation, we're going to cover a number of areas. We're going to try and go quickly to be efficient with your time. We're going to go through federal and state legislative activities as well as a regulatory update. We will discuss the recent activity surrounding patient definition. We will discuss drug manufacturer restrictions and the revamped administrative dispute resolution process, which changed earlier this year. And we will discuss Medicare Advantage considerations, particularly those related to 340B acquired drugs and some litigation that's occurring in that space. And then we're going to wrap with a discussion on HRSA audit activity and additional program considerations for covered entities in today's somewhat challenging 340B environment. So with that, let's get started. 2024 has certainly been an eventful year for healthcare, for politics. There are a number of healthcare programs out there, including 340B, that have been targets. They've become targeted and challenged in this space. So it's not surprising that we are seeing several pieces of several pieces of legislation proposed to change 340B. As a very quick history lesson, the 340B program was enacted in 1992 with the intent to stretch scarce federal resources as far as possible to reach more eligible patients and provide more comprehensive services. So today we really have two schools of thought when it comes to the 340B program. So one is the program is operating the way that it was designed. You've got covered entities that are participating. They are able to provide more benefits to their communities, offer services, have certain clinics open, flu shot vaccines, things like that. They're able to do because of the 340B program. So it's operating as designed, cost taxpayers nothing. We need to protect it and maintain it. That's sort of one school of thought. The other school of thought is, gosh, there's not been a whole lot of change to the program since the 90s. There aren't a whole lot of black and white guardrails or parameters in the program. We need to change that. We need to maybe tighten up some definitions. We need to add perhaps some restrictions, some rules. We need to make sure that we understand how covered entities are using these savings that they're getting. So the 340B program requires drug manufacturers that participate to offer significant discounts to drugs that are acquired under the 340B program. Obviously, every provider out there in the country cannot participate in 340B. You've got to meet certain criteria depending on your entity type, your provider type. For a lot of hospitals in the United States, that means meeting a particular DSH threshold, disproportionate share threshold of patients. So there are a number of bills. It's not surprising that there are a number of bills that are being put forward to potentially do just that, add some guardrails, add some structure, add some definition. And again, you've got kind of both sides thinking about how should we do this? How can we do this? I mentioned those two schools of thought. That's really what I mean when I say both sides. You've got people that are in the camp of let's maintain the program. It should stay, for the most part, similar to how it exists today. They're looking to add guardrails, add parameters, add definitions that help support the program, but that don't limit access or are not overly burdensome from an administrative perspective for any of the covered entities that participate. Then the other school of thought that's saying, we want to understand more about what's happening to the program. We want some reporting. We want transparency. So the bills that I'm going to run through have both of those schools of thought in mind, although some are more provider friendly than others. So the House Energy and Commerce Committee is considering two separate partisan 340B reform bills right now. One is the 340B Patients Act. The other is the 340B Access Act, which I'll discuss in a moment. The Pharmaceutical Access to Invest in Essential Needed Treatments and Support Act of 2024, or 340B Patients Act, it's a mouthful, was introduced back in March by Representative Doris Matsu from California. It was co-sponsored by 9 House Democrats and would prevent drug makers from restricting covered entity contract pharmacy use. It would also levy civil monetary fines on manufacturers for violations. So it would make sure that they have some skin in the game too. It is supported by a number of provider industry organizations, including the American Hospital Association, the Association of American Medical Colleges, and the National Rural Health Association, as well as 340B Health. And it has gotten some additional traction in September. So just last month, Senator Peter Welch introduced the Senate version of the 340B Patients Act. So we'll see how that plays out. The 340B Access Act, or Affording Care for Communities and Ensuring a Strong Safety Net Act, it was introduced in May by Representative Larry Bucshon from Indiana, along with 2 other ENC Republicans from Georgia and my home state of Tennessee. This bill would limit 340B hospital eligibility. It would increase reporting requirements and restrict the use of savings on covered entities. So it would add some restrictions there in terms of how covered entities are using the savings that they gain from the 340B program. It would also codify certain uses of contract pharmacies among a whole host of other changes. It would define the covered entity patient, which has been a subject of much debate that we'll talk about here in just a moment. It would establish child eligibility, and then it would require covered entities to use a sliding fee scale for drug discounts to pass those on to patients. You might be listening to this and thinking, well, that all sounds okay on paper. There are a number of organizations, including the American Hospital Association, that are really concerned about some of the more stringent terms and parameters that are included in this proposed bill. In fact, the AHA submitted a letter earlier this summer expressing some concerns about the impact to existing covered entity providers if this were to go forward. The narrow patient definition, some of the eligibility parameters would tighten. The American Hospital Association actually estimated that about 75% of urban DSH hospitals could be negatively impacted in terms of their ability to access 340B in the future if this moved forward. There's also the 340B Sustain Act. So the Sustain Act was brought forth by a bipartisan group that had actually put this together, requested information from both 340B stakeholders as well as drug manufacturers, and both sides responded with a number of comments. Generally, many of the components were agreeable for provider organizations and favorable. That was definitely reflected in the comments received. There were also some disagreements about the key components concerning the 340B patient definition and the requirements on spending 340B savings. Over the summer, additional bills were introduced that would designate rural emergency hospitals, so REHs, as 340B covered entities, allowing them to also take part in the program. And there were also bills that would extend eligibility to disproportionate share hospitals that are operating and physically located in U.S. territories, allowing them to qualify and participate in the program as well. So again, we continue to see a whole lot of activity in this space. So these bills, along with others, will continue to focus on putting some definitions in place, putting some parameters in place, increased transparency and reporting, and then potentially requiring some additional auditing or at a minimum some reporting of how covered entities are using their savings. So it's definitely fair to say that there has been and continues to be a lot of activity in this space. Whether these things will ultimately impact the way the program operates in 2025 or in the near future remains to be seen. In addition to the federal level regulatory and legislative activity that we see going on, there has been plenty of activity from a state level as well. So the restrictions that are being imposed by various pharmaceutical companies, paired with some of the concern about lack of black and white guidelines and definitions within the program and leaving a lot of things up for interpretation, has caused a lot of states to take matters into their own hands and craft their own laws around 340B requirements for their states. In addition, there are states that are putting forth proposed actions to help support covered entities in their states not have to be subject to the restrictions from contract pharmacy, from drug manufacturers on contract pharmacy drugs. So right now, you've got drug manufacturers that are restricting access to medications. Across the country, this is happening, and so you've got pockets of states, specifically the states that are pinned on this map, that are taking those matters into their own hands, trying to fight back and say that's not something that is going to be permitted. Pharma has responded, and there are a number of litigation cases out there that are active surrounding this challenge of how do we handle contract pharmacies. Were contract pharmacy dispensations something that was even contemplated when the 340B program was enacted to begin with? And so you've got some folks that say yes, some folks that say no. The reality is most covered entities have contract pharmacy relationships and are expecting to be able to leverage those contract pharmacy dispensations as part of their program and receive those discounts. So again, be aware of what's happening in your state. It can certainly impact your program as you're thinking about your policies and procedures, your operations, things that you might need to do related to reporting. Sorry, I jumped ahead on my slides there. Things that you might need to be doing from a reporting perspective. Definitely be aware of what's happening in your state. So talked a little bit, I mentioned about patient definition being something that is definitely from a regulatory perspective, from a legislative perspective, it's being challenged, it's being brought forth as, gosh, we can't even agree, this patient definition is very gray. And so that is something that is at the heart of most of the legislative activity that we are seeing. Maybe not all, but certainly a lot of it. So it's one of the many gray areas of the 340B regulation. As it exists today, it really hasn't changed much from the way that HRSA defined it 25 years ago. There has since been some interpretations that we will talk about in a second with the Genesis case, but for the most part, a lot really hasn't changed in the 25 years or so that the 340B regulation and patient definition guidelines have been out. So those guidelines state that all covered entities must establish a relationship with their patients such that the entity will remain responsible for their care and maintain records of the individual's health care. And then it goes on to say that an individual is not considered a patient of a covered entity if the only care that's being provided is the dispensing of drugs, whether that is for self-administration or administration in the home setting. So that definition is what all of us within the 340B world have been working with for quite some time. Because of that, it is not surprising that there have been HRSA audit findings surrounding the patient definition for years. Most recently, and probably most notably, was the Genesis case. So the Genesis case refers to Genesis Health. They are an FQHC in South Carolina. They had a HRSA audit, and the results of which caused them to be terminated from the program. And at the crux of that were findings related to the patient definition. And HRSA said, this is above and beyond. This is outside of our patient definition. These patients shouldn't have been eligible for 340B drugs. Genesis said, we disagree. Here's our interpretation. Here's the way that we are understanding and operating our program. Genesis fought this finding in court, and they were successful for the most part. So a South Carolina District Court ruled that HRSA could not require that 340B drugs only be used to fill prescriptions originating from care with Genesis. So that was favorable for 340B covered entities for the most part, but the judge did not declare that this meant that 340B drugs could be used for any prescription for a covered entity patient. So they fell short of that. Genesis had allowed a 2-year look back period when they were thinking about how to define their eligible patient population, eligible patients for 340B. It's interesting to note that when we look at from a bigger picture evaluation and management coding guidelines for professional services, CPT coding guidelines state that for purposes of determining whether a patient is a new patient or an established patient of a practice, there's a 3-year window. So if you've been seen within the past 3 years, you're considered an established patient of the practice. And if you've been seen, if it was beyond that, then you're considered a new patient. So they were allowing us a shorter window than what is allowed under, from a coding and billing perspective, what is understood in the industry from a payer perspective. But they were allowing that 2-year look back period, and they were also taking some interpretations again on how they were operating their program. So that ongoing patient relationship kind of school of thought and the way to look at how you're defining your patient population for purposes of qualifying for 340B, it has been and continues to be an area that is full of lots of opinions and interpretations and has been challenged. But this certainly is an example of covered entities taking a stand, contemplating litigation when they are faced with adverse actions related to their 340B program. And for this situation in particular, the ruling was definitely favorable, although it's important from a covered entity perspective. If you're hearing this right now and thinking, gosh, should we loosen up our patient definition? Definitely think through that, work with your 340B legal counsel as needed, make sure that whatever decisions you make related to the patient definition are included in your policies and procedures, are auditable, are something that you all can support from a risk tolerance perspective within the organization, because that Genesis finding, the courts and HRSA have been very specific to state that that ruling is only applicable to Genesis at this time and can't be used or applied for other covered entities. In fact, there is a statement to this effect on HRSA's website under their patient definition. I think it's their patient definition education session of their website actually lists this out. So definitely take all of those pieces into account. And if nothing else, it's a good time to look at the way that you are defining the, your split billing software parameters, the way that you have your program set up, and see if there are any changes that need to be made there. So I talked a little bit about, from a regulatory and legislative update, things that are happening at the state level, at the federal level, talked about the patient definition, lots of changes, lots of challenges here. And really the heart of a lot of that has to do with drug manufacturer restrictions. So I want to talk a little bit about drug manufacturer restrictions and also make sure everyone's familiar with the revamped administrative dispute resolution process, the ADR process. So in the middle of 2020, during the COVID-19 public health emergency, drug manufacturers really started to somewhat quietly enact policies that were aimed at restricting access to 340B pricing, specifically for drugs that are ordered by covered entities that are intended to be dispensed through a contract pharmacy arrangement. So not necessarily drugs that were going to the hospital for their mixed use pharmacies, but drugs that were going to perhaps a Walgreens or a CVS or some other contract pharmacy location within the 340B program for that covered entity. There was a lot of industry chatter surrounding this. There was a lot of pushback. There were challenges, as you might imagine, because the impact to covered entities on these changes were definitely felt by covered entities, and the impact was pretty significant for a number of providers. And so it's not surprising that the Office of General Counsel heard some feedback, both from covered entities and from manufacturers. This caused them to issue an HHS advisory opinion at the end of 2020 in December. And that advisory opinion essentially walked through their fact patterns, their logic, and essentially stated that participation in the program is an agreement. The pharmaceutical company's participation in the program, that is an agreement to sell covered outpatient drugs to covered entities at a price that does not exceed the ceiling price. And so the advisory opinion went on to state that being part of the program does not limit contract pharmacy arrangements that a covered entity can enter into. So there's no limit on how many contract pharmacy arrangements a covered entity can have. And based on their interpretation, concluded that contract pharmacies are essentially acting as agents of the covered entity under these types of arrangements. So that was definitely favorable for covered entity providers. It kind of reinstated what they felt that they probably already knew, which was we have a right to do this. We have a right to have contract pharmacy arrangements, and we should be able to get 340B pricing and access to 340B pricing for all of our contract pharmacy arrangements under Bill 2 Ship 2, just as we have in the past. Unfortunately, that advisory opinion did not stop the restrictions or even really slow them down. Drug manufacturers are restricting access in several ways. Sometimes they are outright denying 340B pricing for items that are being shipped to a contract pharmacy location. Sometimes they are allowing certain contract pharmacy locations to receive 340B discounted pricing. So they might say you can have a single contract pharmacy that receives 340B discounts only if you as a covered entity don't already also have an in-house retail pharmacy. In addition, there are restrictions that are tied to contract pharmacy dispensation data. So we're now seeing requirements to report de-identified information to 340B ESP. So that data sharing that's being required. The impact to covered entities is huge. They are facing declining contract pharmacy 340B program savings. They are having to make difficult decisions around what data and how to share that data from an administrative perspective. And then last but not least, many are expending funds pursuing advocacy in this space and having to work through the 340B ADR process, which we'll talk about in just a moment. So 30 plus manufacturers are restricting sales despite the statute that requires manufacturers to offer 340B drugs to hospitals at the 340B ceiling price. Despite that the HHS advisory opinion, this is continuing to occur. And when some of these pharmaceutical manufacturers have been challenged, so far, federal district courts and appeals courts have determined that these restrictions are allowed under the 340B statute, which has been a bit of a blow for providers. I do expect that some of this will continue to be challenged, and it'll be interesting to see how it plays out. So we can't talk about what's happening with drug manufacturers without also talking about recent activity from Johnson & Johnson. So Johnson & Johnson had previously published a plan that would require covered entity hospitals to pay the full price for certain brand name drugs and then require them to file a rebate to receive the delta between, or that reduced price discount, the savings that they normally would have gotten initially. They would be getting that money back in the form of a rebate. And so they picked this rebate program for two drugs in particular. It's interesting that one of which doesn't even have a generic equivalent right now, but those drugs were Xarelto, which is an anticoagulant, and Stelara, which is a Crohn's disease medication. So for those two drugs, their rebate plan was that they were going to roll this out to covered entity hospitals. They would not be able to get those purchases initially on 340B pricing. They would have to go through this rebate program. Obviously, it was met with significant industry backlash. Not surprisingly, the American Hospital Association and America's Essential Hospitals contacted HRSA directly with a number of comments. HRSA had responded in writing, and they warned Johnson & Johnson that this rebate program this rebate proposal rather violates Johnson & Johnson's obligations under the 340B statute. They threatened to remove Johnson & Johnson from the program if it continued the rebate plan. Interestingly enough, as you can see from this slide, there were a number of pieces of communication sort of back and forth, volleying on this up until the very last moment, if you will. So Johnson & Johnson held their position. Ultimately, HRSA responded with a warning threatening to remove Johnson & Johnson from the program. If drug manufacturers are removed, they are that penalty is good for a period of a year and comes with a $5,000 fine per infraction. Johnson & Johnson ultimately responded on the day of the deadline that HRSA had given, which was September the 30th, that they would not proceed with their rebate plan, but that they held the position that they felt their rebate plan was permitted and would be the best method to ensuring that 340B drugs only reach the patients in which that they were intended to serve, which is interesting. So it'll be telling to see how this again continues to play out. Absolutely feel that there are other manufacturers out there that are watching Johnson & Johnson, watching how this is unfolding, taking notes potentially for some of their own actions in the future and planning. I don't think we've seen the end of that. So while the Johnson & Johnson matter involves just agreement between J&J as the manufacturer and then HRSA, we're going to pivot a little bit, and I want to talk about the administrative dispute resolution process, which is designed to address disputes, issues between a covered entity provider and a drug manufacturer. So the process itself is not new, but there are some new rules that have gone into effect earlier this summer, June 18th of this year. So there are some key differences. The first is the elimination of legal proceeding rules that were previously in place. There is a reduction of panel size and expectations in terms of the claims involved. There are good faith effort documentation requirements for ADR claims. There is the removal of the $25,000 minimum threshold that previously existed to bring forward claims. And final decisions related to this program are going to be posted on HRSA's website, so they eventually will be available. And it's important for providers to note that manufacturers can also bring Medicaid managed care duplicate discount claims forward. So it can kind of go both ways from that standpoint. So as a covered entity, if this is something that you are being impacted by and you're wondering, is this ADR process something that we should pursue, it's definitely worth taking account to say, okay, what are the frequency of NDCs that are now restricted that we are prescribing? What patient volume does that represent? What drug volume does that represent? What are the savings that we would have had previously prior to some of these restrictions that we've discussed today? Make sure that any communications that you are having with HRSA or with the manufacturer, make sure that you're saving all of those communications. They may need to be included with the complaint in the future. So definitely recommend including, saving those documents either in paper or, in a separate electronic file format. Don't rely just on, a file folder within your Outlook email system or something like that. Make sure it's something that's going to have a good retention period on it in case you need it in the future. Be sure to assess, as I mentioned, the financial damages. What are the impacts to the organization from a 340B savings perspective on these restrictions? If you get into a situation where you are not getting 340B pricing is unavailable, make sure that you're notifying HRSA. Seek assistance. There are plenty of wonderful 340B healthcare attorneys out there that really specialize in this space. So seek assistance if this is a sizable issue for your organization, you're preparing to go down this ADR path. It's worth definitely talking with someone to see if you need some assistance helping prepare your complaint. And then consider negative impacts of contract pharmacy location terminations as well in your planning. And then, as I mentioned earlier, consider all state-specific laws that are surrounding this topic. Covered entities can join together to provide a more cost-effective avenue if needed for claims. This can also help HRSA by avoiding having multiple claims by multiple covered entities. But perhaps most importantly, if you think that this is something that you desire to pursue, if you are evaluating it, don't delay too long. There is a 3-year statute of limitations on claims. So we know that some in the industry, some providers may say, gosh, we kind of want to wait and see what happens with some of these other organizations that are out there first going through the ADR process. That's fine. Just know that there really is a ticking clock on those claims in terms of what can happen after that period. So we've talked a lot about what's happening from a state perspective, from a federal perspective, and then from the drug manufacturer's standpoint in terms of restrictions. I want to switch gears a little bit now and talk about Medicare and Medicare Advantage. So as quick background, I'm sure everyone is aware, Medicare reduced reimbursement for 340B acquired drugs back in 2018. It was effective in the final rule for 2018. The reimbursement previously for separately payable drugs had been ASP, or the average sales price, plus 6%. Medicare reduced that reimbursement to ASP less 22.5% for drugs acquired under 340B. Again, that began in 2018, and that was in place through 2022. During that time period, there was lots of industry pushback, there was lots of activity, and there was lots of litigation in this space. Ultimately, the U.S. Supreme Court found that HHS had violated federal law when it reduced the Medicare payment rates in 2018. So Medicare reverted back to its prior payment policy of paying ASP plus 22.5. That happened in September of 2022 and was in effect going forward up until now, from 2023, 2020, and into 2024, where we are currently. In addition, CMS did a remedy, if you will, for that reduced reimbursement from 2018 through 2022 by giving lump sum payments to providers that were affected. And so those lump sum payments occurred during the first quarter of this year, first quarter of 2024, which was great. That was welcome news, certainly for providers in this space, for covered entity providers. But CMS fell short of addressing how to handle Medicare Advantage claims. Oftentimes, Medicare Advantage historically will follow Medicare guidelines from a policy standpoint. They do negotiate rates and terms with providers, but from a coverage perspective, have to cover the same things that Medicare covers, and oftentimes are paying based on a derivative of Medicare anyway. So it's interesting that there's been no formal announcement really on how to handle these Medicare Advantage claims. There are providers that are saying, hold on a second, you know, I got these monies back from CMS. Why am I not also getting funds back from Medicare Advantage plans? And so there are analyses taking place now. There are evaluations taking place. Generally speaking, your provider agreements, your Medicare Advantage contract terms will dictate how to handle any kind of a dispute on reimbursement, any kind of a dispute on payments or claims. But we really are urging impacted covered entity hospitals to evaluate the impact for their organizations. For some clients in some markets, the Medicare Advantage impacts associated with these reimbursement reductions are even greater than the traditional Medicare impacts. So definitely something to consider and work through, contacting your Medicare Advantage plans, seeing if you are able to get any kind of an adjustment there, or if that's something that could be handled in future contracting and future negotiations for future rate setting. So clearly, there's a lot of change and more anticipated change likely coming with the 340B program. There is some uncertainty around what the program may look like in the future, but for the most part, parties agree that this program is very much necessary, very beneficial, particularly for the covered entities and the patient populations in which they serve. So for the time being, we'd really encourage covered entities to focus on making sure that your program is really a compliant program, is strong. Make sure that you're doing everything that you can from a blocking and tackling perspective. You're documenting everything that you need to, documenting the community benefits that you're able to provide as a result of your 340B savings. It's always a good idea to make sure that you're able to tell your story clearly and concisely as to how the program is benefiting your community. HRSA audit activity has continued. They are back to in-person audits. They have been for a while now. This slide in particular shows kind of the breakdown of audit activity. This is current as of September the 20th, 2024, because that is the last update date that HRSA has on their site. It will continue to be updated, so these numbers may continue to shift slightly as audits are completed or as covered entities that have received audits with findings submit their corrective action plans, and those plans are received, reviewed from HRSA, and accepted. Generally speaking, I think we can expect to see close to the same amount of audits in terms of volume. In fiscal year 2022, there were 199 audits. That dropped down to 159 for fiscal year 2023, although we may still have some activity there that's lingering to get posted. And then so far this year for fiscal year 2024, there are 63 audits that have been posted. Overall findings, if we kind of step back and look globally across those three years of audits, the findings can be summarized as diversion issues, duplicate discount issues, and incorrect OPACE record issues. So duplicate discount issues generally relate to Medicaid exclusion file errors. Either a client hasn't, covered entity hasn't included all of their information correctly on the Medicaid exclusion file, or they've put all of their information out there on the Medicaid exclusion file, but perhaps they've missed an NPI. We see sometimes things like that from time to time that haven't been updated. So that is a finding that has happened time and time again. Diversion is still a finding, although diversion as it relates to 340B is a little different from other drug diversion findings from a compliance perspective. Typically that means that a 340B dispensation went to a patient that it should not have. So that could be related to services that were qualifying that were rendered at an ineligible site, so a location that was not part of the 340B program, or it could relate to patients that were not outpatients at the time of dispensation. So if a patient had been admitted to observation and then transitioned to an inpatient status and then later received a 340B drug, for example, and we see those findings occurring. It's interesting to note that there are no patient definition findings happening right now as we look through. Incorrect OPACE records are a mixed bag. A lot of times those are administrative issues. They are clerical errors. Sometimes if your hospital address is 100 Hospital Drive and you have it incorrectly listed as 100 Hospital Lane, that difference there can be enough to have an incorrect OPACE record finding. So sometimes it's something as minor as that. Sometimes there are a little bit bigger or more substantial issues. So you may have an issue with your cost report filing date or the way that your cost reporting period was listed on your OPACE record. Oftentimes we're saying that contract pharmacy information is not current. So either there's a new contract pharmacy that was added and that information didn't completely transfer over to the OPACE record for that covered entity, or a contract pharmacy relationship is no longer in place. So it's a contract pharmacy that is no longer being used by the covered entity, but they have failed to take it off of their OPACE record. We're also seeing findings related to child sites. So child sites not being listed or ineligible off-site outpatient facilities being listed on OPACE. So kind of works both ways there. So definitely take some time, make sure that you have a clean house, so to speak, on all of those low-hanging items. So I mentioned already, even with all the activity that we've discussed today, some of the litigation, the pushback, and the challenges, making sure that you've got things listed, set up correctly in your program internally is the best thing that you can do to continue to support your operations and continue to support the 340B program and the need for it in this uncertain environment. And when we talk about how to support your program, when we talk about blocking and tackling, some of the things that we're talking about really relate to auditing and monitoring. You should have policies and procedures. You should make sure that those policies and procedures include any updates that might have happened now that we are outside the COVID-19 public health emergency, it's a good time to look back and make sure, is everything that's outlined current? Is it correct? Are the addresses correct? Does this reflect what we are actually doing today? You know, are your provider listings current? I talked about the OPA database issues. You know, those are easy fixes for an organization to avoid having findings later on down the line. We talked about policies and procedures a little bit, but really making sure, and it sounds very simple, but making sure that as you're doing internal checks, as you're doing internal auditing and monitoring, that any of the things that you are finding within an organization, that you're also taking action on that, you're trying to remediate those issues, and you're keeping a good documentation trail and saving those notes, saving those files. In the event of a HRSA audit, HRSA is going to want to see your proof of how you're dealing with your program issues and findings, and that you're maintaining some internal oversight over the program. And sometimes there can be a bit of a gap between the individuals that are responsible for overseeing the 340B program on a day-to-day basis, you know, folks within your compliance team, folks within your pharmacy team, and the individual that's ultimately responsible for signing off and recertifying every year for the program. So that authorizing official. So the things on this slide are the things that are listed on the recertification attestation. So these are the things that your authorizing official is attesting to for each re-enrollment period. So they are attesting that everything on the OPA database is correct, it's accurate, that your contract pharmacy arrangements are in compliance, that they meet the essential elements, that as a covered entity that you meet all the eligibility requirements and that you are going to comply with all of the requirements, that you maintain auditable records, that you have systems in place to ensure ongoing compliance, that you're going to notify OPA if there are any significant changes to your program, and that you understand that you may be liable for any breaches if there are findings later on down the road that result in a 340B drug being given to a patient that was not eligible. So hopefully this content has been helpful as you think about supporting your 340B program and as you think about maintaining this environment going forward. We have more healthcare regulatory roundup materials coming. So next month we will be talking about the final rule. It's kind of hard to believe that it's already here. So we'll have a number of sessions there for you. Thanks so much for being with us today. We appreciate your attendance. Moderator, please close us out.
Thanks to our presenter, Sarah. Later today, you'll receive an email with her contact information and a recording of the webinar. Also, the slides and recordings for every episode of PYA's Healthcare Regulatory Roundup series are available on the Insights page of PYA's website, pyapc.com. While at our website, you may register for other PYA webinars and learn more about the full range of services offered by PYA. Please remember to stay on the line once the webinar disconnects to complete a short survey and post any additional questions you may have. On behalf of PYA, thank you for joining us and have a great rest of your day.